Good evening to all of you. In this class, we will cover some aspects of congenital heart disease, basically focusing on acyanotic heart disease, because otherwise it becomes a very long topic. And I hope to keep this down to 1 hour. In every class, when I begin to prepare, I think that I should have less number of slides and say less. But unfortunately, it always exceeds time. And so this time I've tried to be as concise as possible. So the rules of the game are that this is a revision class, so I will be fast. And for all postgraduates, I would request you to keep answering questions as we ask. You need not tell it openly, but I have a notebook or on a phone so that before the answer comes up, if you answer to yourself, it's one way of checking your knowledge. But since there are no first years, it's only third years and second years, so that is why I thought that I could be a little more fast than my usual classes. So basically, we'll just go through some concepts. Why are they acyanotic? Because they are left to right shunts. So there is oxygenated blood which is coming to the deoxygenated side. So we have all these shunts are going to be acyanotic. When does this translate into symptoms? That we will go through the lecture, I will tell you. Some common findings and some common complications we will put on board before we start the descriptions. The common features are that all of them will cause pulmonary congestion. So there is recurrent respiratory infections, especially in children. And in the two shunts that occur in children, VSD and PDA, they can have also failure to thrive, fatigue during feeding, breathlessness on feeding, sweating on feeding. These are the complaints that mothers bring their children with. And recurrent respiratory infections can come through schooling and adolescence, etc. Ultimately, all left to right shunts will develop pulmonary hypertension. There is no way they can escape that. And once the pulmonary pressure goes up significantly, then they will reverse. And that's what we call as Eisenmengers. So why do they reverse like that? The basic mechanism is that whenever the arteries or a circulation is faced with more blood, if it wants to restrict the amount of blood coming to it, the best way for it to do it is to constrict and so increase the resistance so that the volume comes down. So what happens in all these shunts is they're all high volume on the pulmonary circulation, and so they will increase the pulmonary pressures. Once the pulmonary artery pressures increase, then there are changes in the endothelium and in the muscular walls of the pulmonary arteries. So the endothelium and the muscular walls of the pulmonary artery react to the increase in volume by constriction. And ultimately, these changes, which begin initially as dynamic, will become permanent, which is what we call as pulmonary vascular obstructive disease or PVOD, which is a condition where the pulmonary circulation undergoes anatomical changes, and that is what is causing an increase in resistance to pulmonary flow. And this will become irreversible. At this point, you cannot go back and unconstrict the pulmonary arteries, etc. These are permanent changes, and after that, you can't do much. So this is the end point of all left to right shunts, that they will begin as pulmonary vasoconstriction, but end up as permanent changes in the pulmonary circulation. So the common findings that we find in ASD, BSD, and PDA are that there is an ejection systolic murmur in the pulmonary area. This is a common theme that you'll find in all these shunts. There is a loud P2, that is because of the pulmonary artery hypertension that you have. The ASD, the load is on the right ventricle. The VSD, it's on the right ventricle and left ventricle. And PDA is mainly left. So if you look at ASD, VSD, and PDA, this is like connections at different points in the circulation, isn't it? So ASD is at the level of the atrium, so it falls on the right ventricle. VSD is on the level of the ventricle, so both ventricles are involved, whereas PDA is at the level of the aorta to pulmonary, so only the left ventricle is involved. So it's just imagine that these shunts are happening at different levels of the circulation, and so their findings are different, but all of them translate into pulmonary hypertension. So ejection systolic murmur in the pulmonary area and loud P2 is what we will always see. There are several associations with all these congenital heart diseases, starting from Down syndrome, Ellis-Von Cribald, Opitz syndrome, chondroectodermal dysplasia, Then the effects of rubella. That's why we always ask for maternal rubella when we see a child with congenital heart disease. Then we have Holtorem and Hurler and others. So I'm not going into these details. These can be found from any textbook and you can mug it up. Now, starting from the first shunt that we are talking about, that is atrial septal defect. Now, simple terms, atrial septal defect is a defect here at the level of the atrial septum. So there's blood flowing from the LA to the RA, RA to RV, and then it goes into the pulmonary circulation. It's a left to right shunt. Now, where does the load come on? The load comes on in the RA, and then it goes to the RV, and then pulmonary circulation. But please remember, this blood from the pulmonary circulation has to come back to the LA. So there is a load on the left atrium, and some of the largest left atriums have been seen in ASD. So you must remember that RA, RV, pulmonary circulation, and LA, all of them are affected in an ASD. The only thing that's spared is the LV. Now, like we said, there's pulmonary artery hypertension that translates into a right ventricular hypertrophy. The RA pressures are high. Then at one point, when the pulmonary pressures become so high, then the RV pressure goes high, then the RA pressure goes high, and the RA pressure exceeds the LA pressure. And this is where the reversal will happen, which is when we call it as Eisenmenger's. Like we said, large left atrium, any atrium that is stretched beyond its capacity will give rise to microfibrosis in the walls of the atrium, translating into atrial arrhythmias, especially atrial fibrillation. Pulmonary congestion is a given because you're putting so much blood into the pulmonary circulation. All this has to go to the lungs. So you get pulmonary congestion, and that is what translates into the repeated respiratory infections that we have. Now, why is pulmonary hypertension late in an ASD? Because the pulmonary circuit in an ASD behaves differently. The level of shunt is at the level of the atrium, and the pulmonary pressures do not go up until very late. And so that is why pulmonary hypertension presents late and ASD also presents late. Initially, the pulmonary artery hypertension is flow related, what we call as hyperkinetic pulmonary hypertension in an ASD. Later on, it becomes proper pressure related pulmonary hypertension. So there is a flow related hypertension and there's a pressure related. The flow related hypertension is what we call as hyperkinetic. The P2 can be loud even though there is no increase in pressure. This is the point at which we call it as hyperkinetic pulmonary hypertension. Later on, like we said, vascular changes will occur and pulmonary artery pressures will go up. So this is one unique phenomenon of an ASD where you get a loud P2 in spite of not having an increase in the pulmonary artery pressure. Now let's look at the types of ASD. When we look at the embryology of the ASD, you will remember the ostium primum and the ostium secundum. So the primum, the septum primum begins from the roof of the atrium and comes and completes and joins the endocardial cushion. And for some reason, there develops a break in the septum primum towards the roof, and then there's a septum secundum, the blue line which comes and covers. But the blue line is not again complete. It leaves a gap. The septum secundum also leaves a gap. So ultimately, you get a separation between the atria, but it is like a flap. There is one flap on this side, one flap on the other side. This is the septum primum. This is a septum secundum, but there is a patent foramen ovale, which is like having two flaps on either side, but leaving them not anatomically closed. They are closed by the pressure of the left atrium, closing the flap, but they can be opened, and that is why we call it as foramen ovale. Now, most of the this thing is your atrial septal defect is from the ostium secundum. So that is why this is what is common, secundum ASD, and the primum ASD constitutes a much lesser number of the ASDs that are present. Now, if you look at it from the atrial side, you see that is the primum ASD, that is the secundum ASD. You also have a sinus venosus defect, which can be at the level of the atrial septa, at the superior vena cava or the inferior vena cava. So you got an ostium primum, an ostium secundum, and a sinus venosus type of ASD, which can also occur. So different types of ASD are possible, and their presentations are slightly different as we will go through. What are the clinical features? Let's look at this problem. 60-year-old woman came for diabetic checkup, was found to have a loud systolic murmur in the second left space. What is the diagnosis, findings, and advice to the worried patient? Why I put up this problem is to illustrate the fact that people walk through life with an ASD not being detected at all. So patient did not have any problem. She actually came for something else, and then somebody found a murmur, and then a diagnosis is made, and then you're looking for other findings, and probably you should tell the patient not to worry. Now, what are the symptoms and signs? Like we said, recurrent respiratory infections which can come from childhood, adulthood, etc., since childhood. But mostly presentation of the ASD is in the fourth and fifth decade, when actually other complications of ASD start setting in, and the female to male ratio is 2:1. So you'll find more women having ASD than men. And this is the time at the fourth or fifth decade when they start developing an atrial fibrillation because there's a very large atrium. Remember, atrial fibrillation is never uniatrial, it's always biatrial because the muscle of the atrium goes around the LA and the RA together. So you get atrial fibrillation because both RA and LA are enlarged. Patient presents with palpitations, fatigue, and breathlessness. This is the time at which they present as an ASD. So though it's a congenital heart disease, presentation is late because of the, like we said, the behavior of the pulmonary circuit, which takes a long time to develop pulmonary artery hypertension. When we are examining a patient with ASD, the most important general examination features are to look for Marfan's, which is associated. So always we tell them to students to measure the height and arm span. Syndactyly and polydactyly are known, and Holt-Oram syndrome, which is very famous among postgraduates, where you get abnormalities of the skeleton of the fingers and the thumb, and you can get congenital heart disease in the form of ASD. Now, when you look at the clinical features reflect the pathophysiology. There is a load on the right heart. Like we said, the pulmonary hypertension is there, hyperkinetic or pressure increase, and so the P2 becomes palpable. There is an RVH, so the apex is shifted laterally because there's an RV, volume overload. So the apex will just go lateral. Pulsations are present in the lower left border because of the increased flow into the right ventricle, which give rise to, not only parasternal heave, but also parasternal pulsations. And then the JVP can show a prominent V wave. The LA is dilated, but clinically you can't make out that LA, so that's why you're not seeing it. So these will be the findings on examination of a patient with ASD, that you have an apex which is lateral and right ventricular, and then you got pulsations in the parasternal region. You may get a parasternal heave later, and you get a P2 palpable, and you can get a thrill in the pulmonary area later, but that I will tell you a little later. The JVP can show a V wave. Now, let's look at the link between the pathophysiology and the auscultation. Remember, there is no murmur across the shunt. There is no murmur across the shunt because there is no great pressure difference, no great turbulence happening here. Remember, murmurs happen because of turbulence, no murmur. So there's no murmur across the shunt. So where is the murmur coming from? The murmur is coming from the pulmonary. So that is why you get an ejection systolic murmur in the pulmonary area because of excess blood going through this normal pulmonary valve. And like we said, P2 can be loud because of hyperkinetic or pressure-induced pulmonary hypertension. And then you get a wide splitting of the S2. Now, why is there a wide splitting across the S2? This is because the right ventricle takes a longer time to eject the amount of blood that comes into it. So the right ventricle takes a longer time, so the P2 closes late. So you get a wide splitting of the S2 because of the longer, prolonged right ventricular systole. Then there is a fixed split about which I will talk in a while. And then there is an RVS3 because of increased blood going into the RV. A TRPR can come later when there is development of pulmonary artery hypertension. Tricuspid regurgitation and pulmonary regurgitation can come later. Look at this side. There is a flow murmur, flow MDM, mid-diastolic murmur across the tricuspid area. Now, why does that happen? Because you got blood coming from the veins, you got blood coming from the shunt. All of them are going through the normal mitral valve. So there's a flow MDM because of increased flow across the normal tricuspid valve. So there's a flow MDM across the tricuspid. And if you have a lot of blood in the lungs, you can get what you call flow murmurs on the sides of the chest, which you can auscultate. So this is the summary of the auscultatory findings of an ASD. Remember, nothing across the shunt. All you get is the feature of a P2 loud, ESM, wide split because of the longer right ventricular systole, fixed split about which we will talk, RVS3, PR and TR later, and the MDM across the tricuspid valve. Now let's come to the most important finding in an ASD, which is the wide fixed split. Why wide? Like we told, longer time taken by the right ventricle to eject its large volume of blood that is present. So P2 is delayed, so the split is wider. So that is the A2, that is the P2. P2 takes a longer time. The right ventricle is ejecting all the while. So that is why your P2 is delayed. Now, the most important characteristic of an ASD is the fixed split. Now, why is it fixed? To understand why is it split, you must remember why is it not increasing during inspiration and decreasing during the expiration in the normal person. In the normal person, during inspiration, there is more blood coming to the right ventricle. So the P2 gets delayed because the right ventricle ejects for a longer time during inspiration. During expiration, there is less blood in the right ventricle, so P2 comes early. Now, this is the normal physiological variation of the second sound. But if you had the same amount of blood in the right ventricle during inspiration and expiration, the P2 will close at the same time in inspiration and expiration. That's why it's fixed, because the right ventricle volume has the same volume of blood during inspiration and expiration. Now, why does this happen? During inspiration, we should get more blood from the veins, right? So let's say 200 ml comes from the veins, but you have a shunt, right? From the LA to the RA. Let's say 100 ml comes from the shunt. So total amount of blood in the right ventricle is 300 ml. 200 ml came from the veins, 100 ml came from the shunt. During expiration, let's say the veins do not give 200 ml, but they give 100 ml. Then what happens? The 200 ml will start coming from the shunt because the amount of pressure on the right side is less. So shunt becomes more. So ultimately, the total of the blood in the RV. Sanket, can you move?
Yeah, sorry, ma'am. I did.
Yeah, okay.
Yeah.
I was wondering who's talking now. Okay, so the total amount of blood in the right ventricle remains the same during inspiration and expiration. Normally, you would have had this variation, right? You would have had more blood during inspiration, less blood during expiration. So P2 would have closed later during inspiration and less earlier during expiration. But now you have a shunt that is complicating the picture. So when you get more from the veins, you get less from the shunt. When you get less from the veins, you get more from the shunt. So the total right ventricular volume of blood in inspiration and expiration remains the same. So when you're asked in the exam also, why is the split fixed? This is the sentence that you have to say, because the right ventricular volume remains the same during inspiration and expiration, because the veins and the shunt compensate for each other. Now, that is just to recollect the normal inspiration where the P2 comes late, normal expiration during which the P2 comes earlier. The wide splitting is when the P2 comes late, okay, because of a longer ejection time of the right ventricle. But this also is, though it is wide, it is still varying. You can see during expiration, this wide split is also narrowing. But here in a fixed split, A2 and P2 come at the same time during inspiration and expiration. This is what happens in an ASD. Whereas what we call as a paradoxical splitting is that the A2 comes earlier than P2. Okay, if the A2 comes earlier than P2, which is what will happen in some other conditions, that is when you call it as a paradoxical splitting. So what we are talking about is the third one. This is what happens in an ASD, where there's a fixed splitting because the amount of blood that the right ventricle ejects during inspiration and expiration is the same. What are the common differentials of ASD in in our OPD? Whenever we see OPD patient, he's got a pulmonary ejection systolic murmur, two or three things come to our mind. One is hemic murmurs. You will find a lot of patients with anemia who are having uh, a murmur in the pulmonary area. So these hemic murmurs are part of the hyperkinetic circulation that happens during anemia. Simplest way of eliminating them is to ask the patient sit up, then the murmurs will definitely come down. Idiopathic dilatation of the pulmonary artery, where also when there's a dilated pulmonary artery, you can get an ejection systolic murmur over the pulmonary area. The third condition that we have to consider is a pulmonary stenosis, where there is a flow of blood through a narrowed pulmonary valve, which also gives rise to an ejection systolic murmur. The fourth one is the AST. So if you see only an ejection systolic murmur in the pulmonary area, These are your differentials. And how do you differentiate them? The easiest way to rule out an ASD, the best way to rule out an ASD is to eliminate the wide split and then ask the patient to stand up. Okay, ask the patient to stand up and expire. When you ask the patient to stand up and expire, then what happens is that the width of the split should come down when you stand. When you stand, the amount of blood coming from the veins is less. This is even in a normal person. I'm not talking about ASD. If you ask any person to stand, then the width of the split should come down because the amount of blood coming to the right heart is less because there's venous pooling in the legs. So what happens? Any split that you are thinking is wide. What you do is to make the patient stand up and auscultate. If it is still wide, it is wide. If it is not wide on standing, it is probably not a major width. The splitting is come during expiration. What you do, you ask the patient to expire. When you ask the patient to expire, then the split should narrow. In anybody, it should narrow. But if after standing and on expiration, still there is a wide fixed split, then it is an ASD. Okay. So if you have a doubt about any patient whom you think has an ASD, because remember, you will get no other murmur in an ASD, ask the patient to stand up and hold the breath in expiration. If after doing this, still there is a wide split and still there is a fixed split, now that is an ASD. So you are giving the maximum disadvantage to the ASD by making him stand and making them do expiration. If after all that still there is wide split, then you call it as an ASD. So it's a simple trick that all of us use in the OPD whenever you bring a patient and say, Madam, the split is wide. Then all we do is make the patient stand, ask the patient to expire, re-auscultate, and then find it. Same thing for the fixity. Now, if you look at the causes of wide split, there are many. RBBB because the right ventricle takes a longer time. PS because there's an obstruction. Left ventricular ectopic or pacing because it's like an RBBB. Right ventricular failure or infarction where the RV takes a longer time to eject. And an MR and a VST where the A2 can become early. Now, one of the questions often asked is how do you differentiate a split S2 from an opening snap, from a third sound, from a pericardial knock? So, if you look at all this, you know what is the cause of all this. Split is because of closure of semilunar valves. Opening of the AV valve is the opening snap. Third heart sound is filling of the ventricles, and this is a pericardial knock. The pitch of everything is high except the third heart sound. Third heart sound is a dull sound. It's a dull sound. All the others are high pitch sound. Of course, the duration is least for the split, but we can't really make it out auscultatively. It's difficult to make out how many milliseconds. The position of it, yeah, split sound is in the second space. Opening snap is towards the apex, and the third heart sound is again RV or LVS3. And then this is again lower down. The variation with the respiration happens only for a split. And of course, with the associated findings is how we decide what is it, whether it's a split or an opening snap or a third heart sound or a pericardial knock. Now, one of the questions that's often asked is an AST, though however gross it may be, hardly causes a grade 4 murmur. That's why I did not put a thrill in the pulmonary area as an important finding. Hardly it causes a murmur, grade 4 murmur with a thrill in the pulmonary area. So if you see an ASD with a thrill in the pulmonary area, what do you think of? Two conditions. One is it's a large, high flow ASD, very big ASDs, then only you'll get a thrill. The second condition, ASD with PS. ASD is associated with a lot of other congenital heart diseases. So one of the combinations that you get is an ASD with a pulmonary stenosis, which is when you'll get a thrill. So if you see an ASD with a thrill, either it's a very big ASD, you must have the features of all that, or you must have a pulmonary stenosis. Now, what changes will you get with pulmonary hypertension in an ASD? What will happen to the ESM in the pulmonary area? As I ask you, please keep answering, and then I'll give you the answer. What happens to the ESM in the pulmonary area? It remains. What happens to the tricuspid MDM? The tricuspid MDM, what happens to it with pulmonary artery hypertension? Disappears, isn't it? Disappears because the flow doesn't have the pulmonary circuit pressure goes up, the RV pressure goes up, so you will not get so much flow. So the tricuspid MDM will disappear with the appearance of pulmonary hypertension. Remember, once the pulmonary hypertension starts increasing, you will not get the MDM. So you will not get the MDM in the beginning. You will get it in a moderate shunt, but in a severe shunt, the tricuspid with pulmonary artery hypertension, tricuspid MDM will disappear. What happens to the second sound with pulmonary artery hypertension and ASD? Gets louder and louder and louder. What happens to the split once you get a pulmonary artery hypertension? What happens to the wide split that we are talking about? It will narrow, but it will still be fixed. It will narrow, but it will still be fixed. So that's how you make out that there's an ASD. So these are the changes that you get with a pulmonary artery hypertension. The ESM will grow louder, it will remain, the tricuspid MDM will disappear, the second sound will grow louder, the split will narrow but remain fixed. Now let's look at a problem. 30-year-old housewife comes with increasing breathlessness and palpitations. She had wide splitting in the second heart sound in the pulmonary area. Now, this is a giveaway. Whenever you see wide fixed splitting of the second heart sound in the pulmonary area, okay, fine. That's an ASD. So you can look for whatever other clinical features, you can look for the MDM, etc. But there's one small thing about this problem that you should notice, and that is the age group. So you got an age group where you got, instead of the 60-year-old lady that I showed you, you got a 30-year-old person coming with something like an ASD. So what do you look for, and what are you looking for in this patient? So remember, whenever an ASD is early, what will prepone an ASD is an increase in the LA pressure. If you increase the left atrial pressure, then the ASD will increase, isn't it? So how do you increase the left atrial pressure? You either produce an MS or an MR. So if you have a Luton-Backer's MS or you have an MR, usually associated MVP is there in many ASDs. So either an MS or an MR, which will increase the LA pressure, will prepone the ASD, and you will get a 30-year-old person with an ASD. So whenever you see a young person with an ASD, look for an associated MS or an MR. That's the importance of that problem. Now look at this problem. 50-year-old bank clerk complains of palpitation. She is found to have AF. Heart rate is 120. Examination is normal except systolic movement pulmonary area, wide split. Now this is a typical presentation of an ASD. So this person probably has an ASD presenting at the right age. Atrial fibrillation as a complication comes in as the patient ages and other complications come in. The LA is large. Atrial fibrillation will come in. And this is the typical this thing. But when you see a 30-year-old lady, look for an MS or an MR associated. Now, again, as I ask these questions, please keep answering. What is this? ASD with MR and TR. When you see an ASD with an MR and TR, what do you think of? That's an ostium primum, because ostium primum presents with endocardial cushion defect, which corresponds to MR and TR and an ASD. So an ASD with an MR and TR is an ostium primum. You can also get MBP or TVP, which is giving rise to this. ASD with TR. When you get an ASD with a TR, that's an Epstein's anomaly. When you get a TR and then there is a shunt, which is right to left. Sinus venosus defects. What do you get with them? You can get an associated PAPVC, partial anomalous pulmonary venous drainage can come. When you get an ASD with a cyanosis, what will you think of? What will you think of when you get an ASD with a cyanosis? Either an Eisenmenger's or a TAPVC or a PAPVC, which we will talk about later. So an ASD can have associated these things, like an ostium primum you think of when there's an MR and a TR, an Epstein's when you get a TR. A sinus venosus defects can be associated with the PAPVC, and cyanosis you will think of an Eisenmenger's and a TAPVC. Now let's go on to the investigations in an ASD. Investigations in ASD, this is a very classical ASD with what we call as a jug handle appearance of the main right pulmonary artery. This is supposed to be a jug, that is supposed to be the handle, and you can see the very large pulmonary artery, and of course a very large pulmonary artery here also. And then you got an RV apex, there is a cardiomegaly. Of course, you can't go and see the RV unless you take a lateral X-ray, and there is some amount of pulmonary congestion. So this is called the jug handle appearance, and it's called the hilar dance when you do a fluoroscopy. So there's a cardiomegaly with also you get pulmonary plethora. Now you know the difference between pulmonary plethora and pruning. Plethora means you can trace the arteries, the pulmonary vessels, right down to the lateral 1/3 of the chest X-ray. Pruning, you get very large pulmonary artery, but the lateral 1/3 of the chest X-ray is absolutely clear. Now, plethora means there's too much blood in the pulmonary circulation. Pruning means there is increased pulmonary pressures, but you do not, you got so much pulmonary artery hypertension that the flow is decreased. So this is a worse form of pulmonary artery hypertension. This means excess blood. Now that's a classical ECG of a secondum ASD. You can get an RSR dash that you see here, which is very incomplete RBBB because of the disproportionate thickening of the RV outflow. This is one of the explanations given of why you get the RBBB. There is a right ventricular volume overload. Later on, of course, this ECG does not show it. You can get a right axis deviation of the RVH as the ASD becomes more of pulmonary artery hypertension. But otherwise, this is the very classical RSR dash pattern in V1 in a second of ASD. You can also get what is called this Crotchet sign, which is the notch at the R wave on the inferior leads. You can see the small notch here, which is also supposed to be. This is can come, but it is not a common thing. It can come in any ASD, and we should look for this notching in the inferior wall leads. Now, this patient also has an ASD. What is the diagnosis? Just look at this ECG, think over and see what is the diagnosis. That is the RSR dash pattern, but there's one strange thing that is happening here. And if you look at it, that is the left axis deviation. You can see the negative in lead 2. Okay, so that's a left axis deviation. So left axis deviation in an ASD is an ostium primum. Okay, so if you get a left axis deviation with an RSR dash, then you think of an ostium primum defect, which is what is seen in this ECG. Of course, the most confirmatory investigation is either transthoracic or transesophageal echo, which is showing the gap in the septum, and it is showing on the color Doppler. You can see the flow. Now, let's look at this problem. 45-year-old lady comes with breathlessness. She has mild cyanosis and an ejection systolic murmur in the pulmonary area with a loud P2, with a loud fixed S2. So everything looks like ASD, but there is a mild cyanosis. What do you think of? That is a partial anomalous pulmonary venous drainage. Now, what is this partial anomalous pulmonary venous drainage? You have at least 2 pulmonary veins going on and draining into the SVC. So obviously, this is getting mixed up here, and you get a partial anomalous pulmonary venous drainage, and you have an ASD also. Then you can have a mixing up of the blood, and you can have some amount of cyanosis. So an ASD with a cyanosis can mean 2 things. It can mean a partial anomalous pulmonary venous drainage associated, or it can mean Eisenmenger's, and the findings will tell you which is what. You can also have a total anomalous pulmonary venous drainage, which is actually all the veins draining into this thing, and you can get all the pulmonary veins coming onto the right side of the SVC. But because of the non-restrictive nature of the ASD, the shunting is more often still left to right. So it looks like an ASD, but it's a total anomalous pulmonary venous drainage. Now, a total anomalous pulmonary venous drainage is a disease of children. Partial anomalous can come in adults, which is why I put it up as a differential. But this is the X-ray that you see in the TA-PVC, which is called the snowman appearance because of the presence of this. Looks like a snowman, and you can see the very large innominate vein and the SVC and the vertical vein, etc. Okay, but this is more of disease of children, so will not come in adulthood. So partial anomalous pulmonary venous drainage is what is important to us when we see something like an ASD. What are the complications of an ASD? You can get an atrial fibrillation. You can get a paradoxical embolism. It can go from the right to the left, and you can get an embolism like that. And you can get pulmonary hypertension. This is not common though. Paradoxical embolism is not common. Pulmonary hypertension is common. Eisenmenger's. Which complication is not common? That I think all of you will answer, which is infective endocarditis. Infective endocarditis hardly occurs in an ASD because there is no jet. There is nothing to come and damage the endocardium. So that is why infective endocarditis is a highly uncommon complication in an ASD because there is no jet, there is nothing damaging the endocardium. Now, what is the treatment for an ASD? When do you treat a patient? The treatment is closure. You can close either surgically or you can do an umbrella closure. When do you treat? Whenever the patient is symptomatic, go ahead and treat. Large and moderate ASDs definitely require a treatment. Because otherwise they'll become Eisenmenger's. The risk of surgery is very low. So please go ahead and operate whenever you want. Okay, whenever. Why close? What will happen if you don't close? If you don't close, we'll get an Eisenmenger's. Of course, you won't get an endocarditis. That's not a problem. But Eisenmenger's will happen. So all ASDs which are symptomatic, which deserve closure, should close. Now, the contraindication to surgery is an Eisenmenger's. You cannot close once they become Eisenmenger's. What happens when you close? The right atrium faces a suprasystemic pressure, not right atrium, sorry, the right ventricle faces suprasystemic pressures from the pulmonary circuit. So the pulmonary circuit is suprasystemic. So right ventricle is suprasystemic. And this then the right atrium also becomes very high pressure. So it is decompressing into the left side. The right atrium is decompressing into the left atrium. You go and close that, then close the ASC, the right ventricle will collapse because the right ventricle cannot tolerate the suprasystemic pressures of the pulmonary circulation. So you go into intractable right heart failure. So every Eisenmenger's is a contraindication to closing the shunt, because when you close the shunt, the right ventricle faces suprasystemic pressures and the right ventricle will collapse and cause intractable right heart failure. So the contraindication to surgery is always any Eisenmenger's. You can also get a patent foramen ovale, which is present in 25% of normal adults, which can open up under pressure. Like in orthodeoxia, one of the explanations given is the opening up of the patent foramen ovale. So that doesn't matter. It's not at all a major thing. So with that, we come to the end of ASD. Shall I proceed, Sanket, to VSD? Or are there any questions that we should finish?
Can you show that slide? What happens in the findings when there is pulmonary hypertension?
Okay.
Yeah.
Yes.
What is usually what the students fumble. So I thought I will focus on this. Thank you.
Okay. Any other doubts? Any other questions?
Ma'am, is there any role for conservative management in an adult with ASD?
Yes, of course. Yes, of course. There is medical management can be done. You can treat it like any other cardiac failure. Every shunt can be managed medically with furosemide, digoxin, whatever, like any atrial fibrillation. I think I forgot to put it up. Thank you for reminding. Yes, we can. The treatment, we should have added medical treatment here. You're right.
Thank you.
Shall we go on to VSD? Shall I proceed?
Yes, ma'am. If any doubt, you can message me also. So I'll convey to ma'am.
Yeah. So, right. So we go on to ventricular septal defect. The commonest congenital heart disease, 50% of congenital heart diseases will be ventricular septal defect, though as congenital heart disease is uncommon. But among congenital heart diseases, VSD is common. Of course, acquired VSD is because of rupture of the ventricular septum during an MI, but otherwise most of the causes are congenital. Now, you can get different types of VSD again. Like we said, we can get a muscular VSD, we can get a perimembranous VSD, we can get a supracrystal VSD. Okay, so different types of VSD are there. And if you look at the embryology of VSD again, it begins as a muscular ridge from the roof of the ventricle near the apex. It goes like that and then joins up with the endocardial cushions, and that is how the ventricular septum is developed. So if you look at the different types of VSD again, like we said, you can get a perimembranous islet type ASD, which is what you call as A here, perimembranous trabecular, which is B here, perimembranous infundibular, which is C here. All of them are perimembranous. So this is the membranous portion of the septum. This is the muscular portion of the septum. And so this is the area where you get perimembranous VSD. Then you can get an inlet muscular VSD, which is what is here, trabecular muscular VSD, which is what is here, and infundibular or outlet muscular VSD, which is what is here, and you get a supracrystal VSD, which is what is G here, right up. Okay, so basically we're looking at perimembranous, muscular, and maybe infundibular and supracrystal. As we go by, we will describe what happens in each of these. There is also one Swiss cheese VSD, which is multiple small holes in the muscular septum, which are more difficult to close. And this is called Swiss cheese because of its resemblance to Swiss cheese. Then you have the Gerbeau defect, where there is a high VSD. So you get a communication between the LV and the RA because it is located on the membranous portion. It's uncommon and it is usually small. There are many genetic associations, like we said, in Down syndrome, can also occur in Voltarum. It can occur when you have a maternal rubella or a CMV in pregnancy, etc. How do we say what is the size of the VSD? It's always a comparison with the aortic root. If it is less than 1/3 of the aortic root, it is small. If it is less than half, then you call it as moderate. Equal or larger than the aortic root, then you call it as large. And it can be restrictive or open. Restrictive means small, whereas open means it's a very big VSD. So look at the VSD pathophysiology. It's a communication at the level of the ventricle from the LV to the RV. So let's look at what happens here. So you have the communication here, and then through the communication, the blood comes to the RV, goes to the pulmonary circulation, comes back to the LA. So load is on RV, pulmonary circulation, LA, and the LV, because it's receiving whatever it pumped out also, it's coming back again. Okay, so it's getting a double dose. So the LV also is at risk of overload, volume overload on the LV. So consequences are pulmonary congestion initially, later on pulmonary hypertension, biventricular hypertrophy, because you got the RV also facing load, LV also gets back the volume that's coming back from the pulmonary circulation, Heisenberg's, and endocarditis, which we will talk about. Right. So let's look at this problem. 20-year-old boy has breathlessness on exertion. As a child, he was prone to colds and coughs. He has a 3/6 systolic murmur in tricuspid area, which increases on expiration. Now, there is the clue to you. Though it is tricuspid area, but it's increasing on expiration. Systolic murmur, what is the diagnosis? Is 20 years old, prone to cold and cough. So that's where we make the diagnosis of a VSD. Now, what I want you to do is to predict these other findings. What will you get on palpation? What will you get on auscultation? Okay, let's look at what will you get on palpation. LV apex, volume overload. So definitely that high LV apex will be hyperdynamic, shifted down and out. Parasternal heave will come because there's an RV overload also. There's a thrill at the lower left sternal border. That is because of the presence of the shunt there. The shunt happens between the LV and the RV. So that's the area where you get a thrill on the left sternal border. P2 will become palpable because of pulmonary artery hypertension. What will you get on auscultation? Of course, the most important finding is a pansystolic or holosystolic murmur between the S2 and S1 and S2. That is the most important finding that you have. In addition, you get an MDM at the apex, that is because of the flow, and you get an LVS3, and P2 is loud pulmonary area ESM, this you know. I'm just going to go back a little. Okay, now why do you get the flow MDM? That is because you're getting the blood which comes to the RV, goes to the pulmonary artery, goes to the LA, and comes back here. So the load is falling on the LA, and a lot of blood is coming back from the LA to the LV. So here is where you get the flow MDM in a VSD. In an ASD, you got it here in the tricuspid. Here you are getting in the flow MDM at the apex. So that is what is written here, flow MDM at the apex, LVS3 because of volume overload, and the pulmonary hypertension features which are common to all shunts. So what are the symptoms and signs? Depends on the size of the defect. Small VSD will walk through life without any problem. Large VSD will present as infancy only. Failure to thrive and the usual things that we told, recurrent respiratory infections. The pulse will become modified, collapsing because of the increased ejection volume of the LV. Because of that, increased systolic pressure can come, so you can get what is called the modified collapsing pulse. Biventricular hypertrophy, apex also, parasternal heave also. Apex becomes hyperdynamic, parasternal heave is present. Auscultation, like we said, depends on the size of the defect. Usually you get a pansystolic murmur in the third and fourth parasternal region. The murmur is inversely proportional to the size. The smallest of murmurs gives rise to the largest of smallest of defects give rise to the largest of murmurs. So you get a Melody Roger. This will give rise to 4/6 or 5/6 murmur. So the bigger the VSD, the less is the murmur. The smaller the VSD, the more is the turbulence and the louder the murmur. Increase on expiration, LVS3 will be present. P2 loud, ESM split will be normal. flow MDM in the mitral area, especially the shunt between pulmonary and systemic, is just 2:1 shunt. Then you start getting the flow MDM. Now, what are the differential diagnosis of left space, third and fourth space murmur? You got a VST, you got a TR, you got an infundibular PS. 3 murmurs occur in that region. So VST usually third and fourth space, TR usually fourth space, infundibular PS higher, third space. Respiratory variation, this increases on expiration, this increases on inspiration. Both are right-sided murmurs, increasing on inspiration. P2 loud, PH will be present. P2 loud or normal depending on what is the cause of TR. If it is secondary to pulmonary artery hypertension, then it will be loud. If it is an isolated TR because of something else, TVP, infected endocarditis of the tricuspid valve, and whatever else, Epstein's, all that, the P2 need not be loud at all. In an infundibular PS, the P2 is typically normal. Nothing happens to the PS because P2, because it's infundibular and not a valvular PS. So 3 murmurs at that area, and this is how you differentiate between them. Now let's look at this problem. 45-year-old male comes with breathlessness on walking uphill since few months. He's tired easily and can't do even routine work of late. Physician thinks he has an ejection systolic murmur in the pulmonary area with a loud single sound. A loud single sound. He has cyanosis of digits on walking. What are the possibilities? So he's a 45-year-old male coming with breathlessness. He's got an ejection systolic murmur in the pulmonary area with a loud single sound. Okay, you have to find out what this sound is. If you think it is P2, then yes, ejection systolic murmur with a loud P2 is a pulmonary artery hypertension. But he's got a cyanosis also. So what are your possibilities? That could be an Eisenmenger's VSD. Why we are saying that's an Eisenmenger's VSD? Because you got a pulmonary artery hypertension. Let's assume, for argument's sake, let's leave out the A2. Let's say this is a P2. Okay, there's a P2 loud and there's an ejection systolic murmur. That's pulmonary artery hypertension. But you got a cyanosis, right? You should think, okay, why can't it be a primary pulmonary hypertension? You got a cyanosis there, and especially on walking. So that suggests a bidirectional shunt. Shunt is becoming bidirectional. That is why it's beginning you will get only on exertion. Later on, even at rest, you can get. Okay, so possibilities are that you get an Eisenmenger's VSD where the second sound will become single because there is only one, same pressure is there on right and left side. Both A2 and P2 are closing at the same time. So you will get a single second sound, unlike in an ASD where the pulmonary artery hypertension is there, the P2 will be, the S2 will be split narrow, but it is still fixed. Here it becomes a single sound. So this is how an Eisenmenger's VSD will present. Now, what you notice is, where is that murmur of the VSD? It's gone, isn't it? It's gone. That is because the pressures are equalized. So let's look at this slide. What changed with pulmonary artery hypertension on auscultation in a VSD? Pansystolic murmur may become shorter. As the pressure equalizes between the left and right side, then the tendency for the left to flow to the right becomes less and less and less. So the murmur becomes shorter, early systolic, like that. From the holosystolic or pansystolic becomes early systolic, and when the pressure equalizes, then it goes. So it will disappear when the pressure equalizes. That is why that man there, which I showed you in the problem, did not have a murmur across the VSD. P2 will become loud, of course. S2 is split, narrows, and then becomes a single S2, which is characteristic of a VSD. The MDM at the apex will disappear. Of course, it will disappear. Not much flow. Not much flow can happen on the MDM because the pulmonary artery hypertension is so much that the pulmonary flow comes down. So the MDM at the apex will disappear when you get significant pulmonary artery hypertension, and cyanosis and clubbing will appear. So these are the changes with pulmonary artery hypertension in a VSD. The murmur becomes shorter and will disappear. P2 will be loud, S2 will be split, then it become narrow, and it becomes single. The flow MDM will disappear. Cyanosis and clubbing appear. So when you see an Eisenmenger's complex, this is what happens to the pulmonary artery. It becomes very thick. When it becomes very thick and the hypertrophied right ventricle, there is a reversal of shunt from this thing to RV to LV. That's why I said there is no flow MDM. There's no much flow happening at all. So all features of pulmonary artery hypertension, including the A wave, will come in. Pulmonary systolic, this thing, parasternal heave will come, TR will come, PR will come, right heart failure will come. All these things will come because there is a reversal of the shunt at this level. Now, cyanosis and clubbing are features of Eisenmengers, which can happen in a VST, which can happen in an AST, which can happen in any shunt that is reversed. Now, look at some of the strange features of some of the lesions. So you got a supracrystal VST. Let's look at a supracrystal VST. The murmur of a VST, which is supracrystal, goes higher up. So you get a second or third left space murmur in a supracrystal VST. So it becomes a differential diagnosis more for an infundibular PS, even for a PS, it goes that side. Often associated with an AR, because it's close to the aortic valve will tend to prolapse into this. And this is what makes the supracrystal VST dangerous, because it attracts a prolapse of the aortic cusp. Fine. A 35-year-old lady presents with fever of 2 months duration. She finds it difficult to do routine work at home and can't climb to the first floor of her house. She has clubbing and pallor. Pansystolic murmur along the left sternal border. There's an ESM in the pulmonary area and a loud P2. What is the diagnosis? So she's got a pansystolic murmur left sternal border, ESM in the pulmonary area, loud P2. This translates into pulmonary artery hypertension, probably due to this. This could be a VST, this could be anything, whatever you want. There is a clubbing and a pallor and a fever. So then you think of infective endocarditis. 2 months fever, clubbing, pallor, and then you got a murmur in the heart. That is when you have to decide whether it's a TR or a VST, you have to decide. But if it is a TR, then you have to think why she's got pulmonary artery hypertension. So that is why we will go more in favor of a VST in this problem. Otherwise, it's difficult to differentiate. Of course, you can look at your variation with respiration. So what I want to emphasize is that infective endocarditis is an important complication of a VST. Now, where will that infective endocarditis occur? It will occur on the right side. Remember, the jet is this way, so it will come on the right side. So the septal leaflet of the tricuspid valve is where you will get an infective endocarditis. And what will it present as? It will present as a PUO or a recurrent pneumonia, because this vegetation, this will cause more fever. I mean, it will go into the pulmonary circulation, so infections can come. So you can get a recurrent pneumonia, or you can get as a PUO. So that is where you get. Now, look at the investigations for a VST. It's a biventricular hypertrophy. Right and left ventricle is there. There is a plethora, and there's a pulmonary artery hypertension. There is no bay at all. It is full up, and there is a plethora there. The ECG, all of you know, the equidistant complexes of the R and S in the mid precordial leads, which is what you call as the Cash-Vaschel phenomenon, which is seen in this ECG, is what is common, suggesting a biventricular hypertrophy. And this is seen on the X-ray like this. Echo is the most important investigation. So you can see the VST there between the RV and the LV, and you can make out the presence of the jet on the VST. And you can see here on the membranous VST, you may have to do a parasternal long axis view. Sometimes you have to do a TEE also to make out that there is a small VST. This is especially important when you have infective endocarditis. When you want to really make out, sometimes you have to do a TEE to find out, especially if there are high VSTs which are present, which are not really made out on your transthoracic echo. Now, cardiac cath in a VST is needed only to decide when operability, when pulmonary hypertension is high, when you want to quantify the pulmonary to systemic circulation, how much is the volume, then you can do the cardiac cath. Otherwise, it may not be needed. Now, let's look at one more problem. What is your advice to an 8-year-old child's parents who's diagnosed, the child is diagnosed to have a VST? What would you advise these parents? Go for closure, go for a medical condition. What do you want to do? Now, please remember, most small defects will close by 10 years. So you give the child 2 more years, because many small VSTs will close. Perimembranous especially can close very fast by year 2. By growth of septum, even muscular VSTs can close. Infundibular can close because of prolapse of the aortic valve, but this may cause AR, and that is not a good thing at all. So we can wait for some more time. If still small, leave it alone. Watch for endocarditis. Okay. So you tell this child's parents to wait for few more years. Up to 10 years, you can wait, reassess the child and take a call. Then your indications for surgery are that if you have symptoms, you have a large VSD, you have a moderate VSD with a 2:1 circulation, those are your indications, like what we always say. Now let's look at the comparison of clinical features between small, moderate and large VSD. So ventricular hypertrophy is not there. moderate LV plus RV, this also you get both ventricles. Pulmonary hypertension is a feature of moderate and severe VSD, large VSD. P2 is normal here, loud, loud. Pulmonary ESM is present in both these conditions more for a large VSD. The MDM at the apex will be present only in a moderate. In a large VSD, it may go off because pulmonary hypertension will set in. The VSD murmur is loudest in a small VSD, less in a moderate, and in a large VSD, when the pressure equalizes, it can be 2 or even 0. There may be no murmur if the VSD is so large that the pressure is equal and the flow doesn't, cause turbulence at all. VSD with pulmonary artery hypertension, pansystolic murmur, whereas when you get a large VSD with a severe pulmonary artery hypertension, the murmur may become early systolic or may disappear. So this is how you compare a small, moderate, and a large VSD. What are the associations of a VSD? VSD with an infundibular PS is what we call as an acyanotic fallow, and this is the fallow's anatomy, and then that is why it's called acyanotic fallow. VSD with AR is prolapse of the cusp, especially in an infundibular VSD. VSD with MR and TR is an endocardial cushion defect, and as part of fallow, you can get a large non-restrictive VSD. So many associations can come with a VSD, some of which I have put it up here. Treatment, I forgot to say it in an ASD. Thank you for reminding whoever reminded me. Like we say, treat like conservatively. If you don't require surgery or the patient cannot afford furosemide, digoxin, oxygen, infected endocarditis prophylaxis. Now this I will not say here because current guidelines for an infected endocarditis prophylaxis do not exist for any of the shunts. So this is probably not right in today's world. What is the indication for VSD surgery? Large VSD, moderate VSD 2:1, associated AR, even if small, because it can be progressive, symptomatic patient. Contraindication is an Eisenmenger. So these are your indications, like we said, and contraindication. Eisenmengers, can they get pregnant? Yes, if up to moderate, they can get. And what is called Gussel's phenomenon is a large VSD with a right ventricular outlet hypertrophy, and this may become what we call as an acyanotic fallow. Anatomically, okay, right. How do you close a VSD? You can either close with a device or you can do a surgery. This is the Amplexer device, which has got a waist and then it has got two sides, which is made of polyester fabric, and it can be put there. Okay, so you can either close surgically or you can close with a device. Okay, with that I will finish VSD. There are any questions? The PDA part is small. I'll take another 15 minutes with your permission. Are there any doubts on the VSD component?
Ma'am, one message I have received.
Yeah.
That is for AHT mode.
Yeah.
Do all form of AHT cause the wide split or only the ostium secundum?
All of them will cause a wide split, because when there is an equalization, I mean when the P2 is delayed and the amount of blood coming to the RV is the same, then they will cause. There is no difference in that. And MR and a TR, when an ostium primum comes in, even then you get it, because there is both sides, MR, TR, both are there, and then there is an ASD. So it will come the same.
One more question. Interesting. Is there any value of ACE inhibitor, ARBs, or spironolactone in VSD?
Right. Can use an ACE inhibitor, ARB, or a spironolactone. All can be used. I didn't put up the full medical management, but yes, they can be used, because the limiting factor for an ACE inhibitor is only your blood pressure. As long as the blood pressure is there, you treat it like any cardiac failure. There is no difference.
Okay, ma'am. Yeah, these were the two I received.
Okay. Shall I finish off the PDA, the next part?
Sure, ma'am. We'll move to PDA.
Okay. I'm overshooting by another 15 minutes. Okay. I'm not able to come into 1 hour.
No, it's completely fine, ma'am. It's very interesting to revise. Yes.
Okay. Right. Okay. So we go to PDA, patent ductus arteriosus. Let's look at this problem. 28-year-old salesman complains of tiredness on exertion. His BP is 170/70. And he has a collapsing pulse. He's referred for hypertension. People think he's hypertensive. He's young hypertensive. That's why he's referred to you. There's a continuous murmur in the first left intercostal space. What other findings will you look for? Now, this is the presentation of how we get in a PDA. This is the most important finding is what I've given here. Continuous murmur in the first left intercostal space. And I will tell you why he can get a collapsing pulse and why he's got the high systolic that we will look at. So the continuous murmur, what is a continuous murmur? Sometimes we need to know what is a continuous murmur. Continuous murmur is a murmur that begins in systole and continues without interruption and envelops the second sound throughout diastole or part thereof. So the murmur that disappears completely before the next first sound is still considered continuous. So you should not think you should go and touch the next first sound. It should just go past the second sound. Okay. The systolic part of it continues without interruption of the second sound. So remember this, any murmur that goes past the second sound is a continuous murmur, need not go and end in the next first sound. Whereas a systolic or diastolic murmur has a gap. So there is a gap between the systole and diastole, then you don't call it a continuous murmur, you call it a systolic or diastolic murmur. Now that's the PDA. So you got a PDA, you got an aorta, you got a pulmonary artery, that's the ductus. So from the aorta to the pulmonary artery, blood is always flowing through the patent ductus arteriosus, which should have normally closed. So what is the embryology of the patent ductus arteriosus? It is the sixth left aortic arch, which is there, which is connecting the left branch of the pulmonary artery and the main pulmonary artery to the aortic arch. This is the vestige of that. This should normally have closed. In fetal circulation, actually, this is the main source of systemic circulation, because remember, lungs are not expanded in the fetal circulation. So all the blood comes from the pulmonary artery, goes here through the PDA in the fetal circulation. But when the lungs expand with the first breath, this should actually close. It's not closed, then you call it as a PDA. So it's a vestige of the sixth aortic arch. Now let's look at this pathology, pathophysiology. That's the aorta. This is the pulmonary artery. From the aorta, you get the flow into the pulmonary artery. What keeps the PDA open is the PGE2, the prostaglandin E2. The placenta is a big source of prostaglandin E2. So that's what keeps it open during fetal life. When does it close? 10 to 18 hours after birth. What closes it? Oxygen. Oxygen, the first breath that the child takes, the infant takes, that is what releases oxygen, and oxygen causes constriction of the PDA, and you remove the placenta, so the PGE2 goes off. So that is when the PDA will close at birth. Now NSAIDs can keep because they are prostaglandin antagonists, they can close. It's kept open for a longer time in a premature infant and can be open till maximum of 3 months. Okay. When is it useful to have a PDA? When you don't have a pulmonary flow at all. When you don't have, suppose you have pulmonary atresia, Fallows, PS, which is very bad, then good to have a PDA, because at least some blood will go into the lungs. Okay, so sometimes you remember your Fallows tetralogy correction surgeries, one of them was to create a PDA because you had to oxygenate some blood. Okay, so this is what we must remember, that it's something that has to close at birth but kept open. So it's a shunt. Instead of having an ASD here or a VSD here, you put a shunt further away, that is a PDA. What are the consequences? Pulmonary congestion, because every blood is going into the pulmonary arteries, pulmonary hypertension, left ventricular hypertrophy, because you see most of the blood is coming into the pulmonary circulation, coming into the LA and the LV. So RA and RV no way involved. So you get left ventricular volume overload, left ventricular hypertrophy. Further, it can become it can reverse when the pulmonary artery pressure increases, then the flow will reverse here. That is when you'll get an Eisenmenger's, and you can get an endarteritis, which I will talk about later. Presentation, failure to thrive, difficulty in feeding, recurrent respiratory infections, depends on the age of presentation. Is early, but depends on the size of the PDA. Again, how much is the size? That causes the presentation to come earlier or late. And presentation in adults, depending on size, breathlessness and fatigue are usual features. Symptoms and signs, same thing. Okay, signs we will go for collapsing pulse. Why collapsing pulse? Because higher systolic pressure, because more LV output, okay, and runoff from the aorta, so lower diastolic, so that widens the pulse pressure. So you got a high systolic, lower diastolic, collapsing pulse. One of the causes is a PDA. Suprasternal pulsations can be there because of the dilated aorta. You can get suprasternal pulsations. Apex is hyperdynamic, down and out apex, and hyperdynamic. LVS3 can be there, palpable sometimes, and P2 can be palpable, and there is a first space thrill. This first space thrill is because the PDA occurs at that space, right? So why is it continuous? Because throughout the aortic pressure is more than the pulmonary pressure. So that's the continuous thrill that is present. So all signs of LV overload and pulmonary artery hypertension, and then the first phase thrill. What do you get on auscultation? Continuous murmur, which is called missionary murmur. So that is because the aortic pressure is always higher than the more than the pulmonary pressure in diastole and systole. So continuously blood is flowing, and this is where you get your first left intercostal space is where you get the thrill and the murmur. It's a continuous murmur. Paradoxical split of the S2 because the aortic ejection takes a longer time. All the blood which you sent out to the aorta goes to the pulmonary artery, comes back to LA, comes back to LV, and then it has to eject so much longer. So the A2 becomes later and later and later, and then it becomes paradoxical. P2 can be loud because of pulmonary artery hypertension, and you can get a flow MDM on the mitral area because again, whatever blood you sent to the lungs came back through the LA to the LV. So you get a flow MDM, and an LVS3 can be there because of volume overload of the left ventricle. Why is it? What happens to the murmur and S2 in pulmonary artery? Why is the murmur continuous? Because aortic pressure is always higher than pulmonary in diastole and systole. Okay. When will it become systolic alone? When will this murmur become systolic alone? When you get pulmonary artery hypertension, because at that time the diastolic pressures may be equal and the systolic pressure alone may be so much higher. So as you get pulmonary artery hypertension, this continuous murmur will become only systolic. Okay, this murmur in the first place will become only systolic when pulmonary artery hypertension sets in. What happens to the split? It will be initially paradoxical, then it will move, it will become normal, and then it will become narrow like any pulmonary artery hypertension. So there is a movement of the split from paradoxical to the normal when the A2 starts closing, not so late, and then it becomes pulmonary artery hypertension. So you get a narrow split. So the whole thing reverses in a PDA. What will happen when the pressure equalizes? Silence across the shunt. There will be no murmur across the shunt. Okay. And then you will get a cyanosis. But this cyanosis is only in the legs. Differential cyanosis. That is because the PDA, if you see, let me show you. Sorry. The PDA, if you see, is beyond the subclavian artery. So that is why the subclavian artery would have taken off from the aorta here. So the shunt is after that. So this, if you reverse it, then it will go only to the legs. So that is why you get a differential cyanosis. The differential cyanosis comes because it's a post-ductal shunt. What are the causes of continuous murmur? These are the causes of continuous murmur. The PDA, which is called the Gibson's murmur, missionary murmur, train intolerant murmur. The other causes are an AP window, because always the aortic pressure is more than pulmonary pressure, rupture of sinus of Valsalva again, coronary AV fistula, pulmonary AV fistula, arm AV fistula, all the AV fistulas. Pulmonary atresia with bronchial collaterals, because if you get very large bronchial collaterals, they also will cause a continuous murmur. Then truncus arteriosus, mammary souffle, when the lactating woman, you can get mammary souffle, and a venous hum. These are the other causes of a continuous murmur. Now, what is the differential diagnosis of a PDA? It's a VSD with an AR, systolic or diastolic murmur. It is not a continuous murmur. And when it becomes pulmonary artery hypertension, then PDA with pulmonary artery hypertension will look like any other cause of pulmonary artery hypertension. That's when it becomes only systolic and the P2 is loud. Now let's look at this problem. A 35-year-old lady comes with recurrent pneumonia. She's worked up for an immunocompromised state and is negative for an immunocompromised state. She has a collapsing pulse, ejection systolic movement in pulmonary area, loud P2. Now this is a giveaway, like we said, it is a collapsing pulse. There is this thing. So there's a pulmonary artery hypertension, there's a collapsing pulse, and then what findings would you look for? You look for a first phase murmur, and like we said, you can get recurrent pneumonia because of pulmonary endarteritis. Remember, where will the infected endocarditis? It's not an endocarditis. Remember, it's called an endarteritis. Why is it called an endarteritis? From the aorta to the pulmonary, where the jet hits the pulmonary artery, that is where the endothelium will go for roughening, and that is where you get your vegetation, and from that vegetation you will throw emboli into the lung, so you can get a recurrent pneumonia. So that is what I have showed you here. So it's a pulmonary endarteritis that can come in a PDA. It's not an endocarditis. So 15-year-old girl comes with increasing breathlessness, toes are bluish and swollen. Look at this very interesting photograph. There is a cyanosis here. There's no cyanosis here, right? That's a differential cyanosis only in the legs, not there, because this reversal is post-subclavian. Post-subclavian only, the duct is present. So then it goes, the reversed shunt goes only to the legs. And so this person is showing a differential cyanosis. So if you look at where you get your murmurs in the three shunts, that is where you'll get your first space murmur, which is your PDA. Okay, first space, first left intercostal space. This is your PDA murmur. This is the AST murmur. No murmur across the shunt, but only pulmonary murmur. That is your VST murmur. So if you look at the shunts, this is how you get. This is a VST. This is an AST, but this is not because of shunt, and that is the PDA murmur right on top in the first left intercostal space. Now, what investigations you get in a PDA? You get the left ventricular hypertrophy, like you see in any other left ventricular hypertrophy, left axis deviation, etc. And look at the chest X-ray. The one important difference in the chest X-ray between an AST, VST, and a PDA is the large aorta. In an intracardiac shunt, like an AST or a VST, the aorta will never be large. So when you look at a shunt X-ray, okay, you got a plethora, you got a left ventricular hypertrophy, whatever you say, and you think there is a shunt, look at the size of the aorta. The aorta is large, then it's a PDA. The aorta is small, it's an intracardiac shunt. It could be an AST or a VST that you find out. So this is showing a large aorta, and it is showing a pulmonary artery which is prominent, and then there is a cardiomegaly. There is also a pulmonary plethora which is seen here, which is suggestive of a left to right shunt. Of course, echocardiogram is the main thing, which showing the shunt between the aorta and the pulmonary artery. You can do a Doppler and you can see. What is the treatment for PDA? What is the indication? Whenever you diagnose a PDA, better to operate because there is a very low mortality. It's an extra cardiac surgery. It's one of the simplest of surgeries. So surgical mortality is very low. So whenever you see a person with a PDA, good to suggest an operation because you don't want an Eisenmenger's to happen. And you can do either a surgery or you can do a coil closure. Here you can go and put a coil and close it with the devices that have been shown. Medical treatment, you can do an indomethacin, especially done when you want to close a PDA in the child. You can give an indomethacin because it is a prostaglandin antagonist. Treat cardiac failure like you treat any other cardiac failure, like somebody asked. You can give an ACE inhibitor, you can give a aldosterone antagonist, anything you want, you can give. Treat it like any cardiac failure. Many patients do actually very well on medical treatment. We should not think that everybody has to be operated. We have to operate based on symptoms, the size of the shunt, and the tendency to develop complications, okay? And the mortality of surgery. How much are you going to lose when you do a surgery? Think of that and then operate. What happens if you don't operate? Your complications are Eisenmenger's and endocarditis. So I'm going to summarize with this one last slide. Let's look at ASD, VSD, and a PDA. Recurrent respiratory infections is present in both, all three. This presents late in the fourth and fifth decade, even later on in life. Based on size can present early, based on size can present early, VSD and a PDA. Ejection, what is the murmur in a ASD? Ejection systolic murmur in the pulmonary area and a loud P2. Here it's a pansystolic murmur at lower left sternal border, then ejection systolic pulmonary murmur and a P2. Here missionary continuous murmur is first space, right? RVH, biventricular, LVH. Fixed wide split S2, split is normal, paradoxical split. MDM at tricuspid area, MDM at mitral area, MDM at mitral area or apex. Endocarditis very rare because there is no jet, there is no turbulence. VSD, endocarditis on the tricuspid side, on the right ventricular side. End arteritis in a PD. Eisenmenger's, P2 is loud, narrow and fixed. Eisenmenger's, P2 is loud, single S2. Eisenmenger's differential cyanosis, okay, I should have put cyanosis also here, cyanosis and clubbing. Here it's differential cyanosis, P2 loud and S2 is narrow. Okay. Last slide. 15-year-old boy finds it difficult to play games. He sits on his haunches when tired. Ask relevant history, guess his clinical findings. Now, that could be either an Eisenmenger's or a TOF. Now, that difference will come from the presence of pulmonary artery hypertension because an Eisenmenger's can also cause squatting. Okay, and cyanosis and clubbing are features of Eisenmenger's. But the big difference between these two is the total absence of pulmonary artery hypertension here, the complete presence of pulmonary artery hypertension, which is the main theme of any Eisenmenger's. There is a rule of thumb. In every patient who is diagnosed as primary pulmonary hypertension, okay, all features of pulmonary artery hypertension, and attempts must be made out made to rule out two important things. One is a left to right shunt, the other one is a silent mitral stenosis. Okay, so whenever this is a damning diagnosis. Well, it's like motor neuron disease in neurology, right? Primary pulmonary hypertension, if you call it, there's nothing much you can do. You can give your elioprost, you can give your, prostaglandin infusion, etc., or bosentan, whatever. But it's a damning diagnosis. Before that, you must always look for a treatable cause, which is a left to right shunt or a silent mitral stenosis. The left to right shunt is what I talked about in this class. I think I've finished. Thank you. Are there any questions?
Yes, ma'am. And thank you for this class. I think for revision, definitely very useful. And it requires a lot of understanding to have this. Yeah. So, ma'am, one doubt is, it's why is the split fixed for ASD but not VSD? Can the same logic apply there?
Why is the fits? No. During what?
S2 split. I also did not get.
No. The S2 is fixed in an ASD because the right ventricular volume, stroke volume, is the same during inspiration and expiration. That is why it is fixed.
Okay.
But that doesn't happen in a VSD, no?
Right. Now, so one more is a single S2 mechanism in VSD.
Yeah.
Why there is modified collapsing pulse in VSD?
Okay. Single S2 is because the A2 and P2 close at the same time. Okay. When you have pulmonary artery hypertension, the A2 is also closing and the P2, the pressures are equal. That's what you mean. In an Eisenmenger VSD, the pressures are equal, right side and left side. So both of them are going to eject at the same time and both valves will close at the same time. So that is why it becomes a single A2 and P2 merge and you get a single second heart sound. And the modified collapsing pulse, what I meant is that you get a increased volume in the left ventricle. So the increased stroke volume of the left ventricle increases your systolic pressure, giving you a little wider pulse pressure. So that's why it's called modified collapsing. Some people don't agree on it. I would suggest that you don't go and tell everywhere, but some people want it. So that's why I just made a statement like that.
And there are 2-3 things what I keep learning here. One is the recurrent infection can be presentation, and that may be the chief complaint. We have to be careful in young people.
Yes.
I have now different perspective for recurrent infection with the primary immunodeficiency, which happens in adult also. But same time, our rules are simple. It's all medicine. Specialties are afterwards. So first, always we need to rule out this cardiac problem and all, and then only we go for immunological workup.
Yes.
Second, very important thing, which was kind of a funny incident, that to a lactating mother, someone told that do not give NSAIDs. Like we use lot, so people curse us for that. But someone told, like in chikungunya arthritis, don't use. What will happen to this ductus arteriosus?
Oh, okay.
I told it is better we give. But the thing is, what is the learning point here is the ibuprofen is one of the best NSAIDs in lactating mother. Shorter action of time, so even just after feeding they can take. It's completely fine to take with lactating mothers. And third, I think, ma'am, what I wanted to discuss is these findings do really help. Actually, it cut short the workup for patient.
Yeah.
But what we see is and I think this is not for exam or academic setup, but echo dominates in all the practice. So I think what will be the indication there we should go, specifically the pulmonary area murmurs and what we get. So when we should push for echo. I think now people order for everything, but still, if we want to be logical there.
Yeah. I should say, I will put it the other way. When you should not order for an echo, right?
True.
Let's look at that. So many times people come with innocent murmurs. Okay, you get innocent murmurs and you get hemic murmurs. You get young people with anemia. You got an ejection systolic murmur in the pulmonary area. People go and ask for echo. Okay, because they think something is going wrong. Now, if you make the person stand up, okay, and that murmur goes off, that's a hemic murmur, or that's some idiopathic dilatation of pulmonary artery. All these conditions really don't require anything, and you should not scare the patient saying that he has got a cardiac condition. Okay. So that is one thing. Now, the second thing is that when people are taken up for surgery, I've seen that, when they are posted for surgery, somebody will detect one murmur. Anesthesia PG will come and say one murmur is there. And then the whole world takes off saying that, oh, he's got a big problem. So then, of course, you can't convince anybody with your clinical examination. You have to go for an echo. I'm not saying no. But some easy things to miss in the OPD are an ASD, because you get a small murmur in the pulmonary area, you completely miss it. Okay. So an ASD murmur can be easily missed. And a VSD murmur can be picked up, and patient can be, where you must realize that when the VSD murmur is very loud and the patient is otherwise asymptomatic, this patient is not at great risk. And no point scaring him, telling that you got a very bad heart disease, etc., because we know that it's inversely proportional. So understanding some of these small things will go a major way. The third thing is a story that I told my postgraduates. I took a class for my postgraduates on congenital heart disease, of course, not in so much detail, but this is a story that I have. Uh, this happened 35 years ago, and when I was a postgraduate, or even more, when I was a postgraduate, uh, I had a patient who was repeatedly admitted in our ward, saying it's a cardiology problem and multivalvular lesion. Everybody had written MSMR, ASAR, everything, and this patient, a young person, he was going around multivalvular lesion, and he was diagnosed those days as multivalvular lesion. Those days echo was not very common, of course, and he was advised actually double valve replacement, and we had referred him to the cardiothoracic surgeon for an opinion, saying double valve replacement is needed, and please discuss cost, etc. And I cannot forget that day at all, when the patient party who spoke Malayalam ran after me and told me that we went to the doctor, but doctor said, so much, you told me 1 lakh. Those days it was 1 lakh. So 1 lakh is not needed for 2 valves and all. It is actually 3,000 rupees. So I was shocked. I thought, who is giving you a valve for 3,000 rupees now? So I went back to the ward and saw the notes. Then I had seen the cardiothoracic surgeon, who was one of my best teachers ever, had written without an echo, very clearly in his very neat handwriting, this patient has a PDA. He does not have a double valve lesion. He has a PDA. And then when I went back and saw, that's when I realized where all of us went wrong, because we were looking at some discharge summary from somewhere else, and somebody had labeled him as multivalvular, or everybody follows. No, see, that bias is there when something is written and put in front of your eyes, you think that is right. So this man had examined the patient. He could not speak a word of Malayalam. I don't think he ever took a history also, because he must have asked for a translation. But he just did a clinical examination and wrote very clearly, without an echo, this person requires a PDA closure. I will do it for 3,000 rupees. So that's when I realized you can get every murmur in a PDA. You can get an ejection systolic murmur, you can get a diastolic murmur, because the continuous murmur was interpreted as ejection systolic and early diastolic. There was an MDM which was called as MS. Okay. And then this murmur was so loud, it was heard everywhere. Everybody thought he's got MR, MS, AS, AR. So that is when I understood that a good clinician can make so much of a difference. Okay.
Yeah.
Of course, echo is there now. I'm not saying no, but I still believe that, for example, I remember seeing this patient with recurrent pneumonia. Patient actually had a PDA endarteritis, and patient presented as pneumonia, recurrent pneumonia, being investigated for everything else. Okay, that's why I put up that problem. So somewhere it will be useful, and I believe that following that arrow of what Hutchison says, that you take a history, do a clinical examination, write down your possibility, go for the investigation. That is the best arrow. That is the best arrow, not the reverse, not everything. No? Then finally ask the history, how old are you? That is not right. Okay.
Yes. Yes. And I think medicine, it always does. Like we learn to diagnose what happened, but the moment we start asking why it happened, we solve the case.
Right.
Most of the times.
Yes.
Yes, ma'am. Yeah. Any other doubt people can ask directly? My message, I have not got any further.
Shall we conclude?
Sure, ma'am. We'll conclude. Thank you.
Okay. Thank you very much. Thank you all.
Yes. Yes.